So thank you, Jennifer. I'll try to be clear as possible for the non-medical people here as well, trying to understand what I'm going to be talking about. But it's basically sort of techniques for opening arteries that are chronically blocked, and how can we apply these techniques to patients who would have SCAD. Like Dr. Supp presented earlier, the guideline is to do conservative management, because usually there's spontaneous healing, but it's not always possible. But PCI overall have not had good results with propagation of hematoma. Although some techniques were presented, like putting the stent distal, proximal, and everything, can avoid propagating the hematoma. But the problem is that the nature of the problem is very different to what we have. So what we have with coronary disease. But although we want to be conservative, in some patients you have to do something. They have ongoing ischemia, they're unstable. Even in the ones who are in shock, even if you put an impella, obviously you won't let the heart go to a big MI. You want to reperfuse the heart, right? So you need to reperfuse this patient. And you're not dealing with a plaque, it's an intramural hematoma. There's been techniques like fenestration with cutting balloon that's been described, but there are other techniques that we tried that we could bring from the techniques we're doing to unblock chronically occluded vessel to the SCAD world. So CTOtechniques for SCAD, there's no description in the literature, so take what I'm saying with a grain of salt, because this is like very emerging, but this is something that I've been doing, and which has had a very interesting result, let's put it this way. But what technique we could do for CTOs with SCAD? Well, we don't have collaterals. We can go retrograde. We cannot do dissection with stingray. We don't have distal vessel. This is very different. There's not much of anything we can do than a STAR technique, which would be the only thing we can basically do. And what is this technique? I'm going to skip this to just say that those techniques, which is basically taking a wire, getting beside the plaque, in the case of what we're doing, chronic total occlusion, is going beside the plaque, in the medium, largely, pushing that wire totally down into the vessel and coming back into the vessel. You're basically doing a bypass within the wall of the artery. And we're doing that for specific cases when they are chronically blocked. Is it a good technique? Well, we've known that it's an okay technique, but if you can do other techniques, they're better in terms of long-term outcomes. We've known that from data and everything. Now, newer techniques yield better results. But the issue with SCAD is that we don't have collaterals, as I said. They're in STEMI, usually. If you are doing something and they're very ischemic, they're in STEMI. So STAR is the only option. So what is STAR? And we have what data we have on STAR? What the original publication from Colombo showed like a 50% restenosis or reocclusion rate. So what Colombo was doing, he was pushing, not necessarily with a microcatheter, the polymer jacket wire was either whisper and then unpredictable reentry in either of the branches. There was a lot of BMS in that time, so we didn't know if that was because of the technique or the BMS. Then Mocamino from Italy introduced the contrast-guided STAR, which is going beside the plaque, shooting contrast, and reintroducing going back into the vessel. Showed good result, a bit more restenosis, but if you look on freedom from cardiac death, this was a reasonable outcome. We have reasonable outcome. The mini STAR has been introduced afterward using smaller wire to do that dissection into the vessel and then coming back. So some of the people here might be like frightened because you're saying I had a dissection that was spontaneous. What you're telling me is that you are actually causing dissection in some patient? The answer is yes. It depends on what you're dealing with. Some of the patient we will cause dissection and we want that to happen and re-enter. This is to get around a blockage. So what is the outcome if we do that technique? It's quite good, but it depends if we're able to get good flow at the end once we've placed the stent. So if you get good flow and you have the stents placed, your patient are doing usually good. Overall, the result that with the STAR technique have not been tremendous. It remains a last resort sort of techniques. We have better techniques for chronically occluded vessels. However, if you can achieve good flow at the end, this is a reasonable technique. My friend Bill Lombardi from UW did some analysis on some techniques that we're doing more and more. And when we're trying to open those vessels and we fail, because we've tried many techniques. So what we've discovered is that if you induce some dissections in the vessel and let this heal, like a SCAD heal, sometimes you bring the patient afterward and Mother Nature does some magical stuff for you. And then you're coming back and the artery is easier to treat. So they've shown that even if they fail their treatment, if they would induce dissection, it's not, then if the patient comes back, you would find the vessel being much more favorable, and then you could reopen that vessel in 88% of the cases. So I'll show you a case of, I call it SCAD, it's Stephane-induced coronary artery dissection. It's not spontaneous. Stephane, it's me. So it's a CTO is a vessel, so you can see on that picture where the arrow is, you can see there's an absence of vessel between the line up to the reconstitution. So this vessel is filled by what we call collaterals. Collaterals is like a spare wheel of your heart. When you an artery is blocked, you will grow some little bypasses, natural bypasses that fills the artery. So you can sometimes use these bypasses to get into the artery, but you know what? Our intention is to unblock this vessel. So we use different techniques to get into the vessel, and to make a long story short for the interventional cardiologist here, we're doing integrated dissection re-entry with a stingray, and we're filling and we're trying to get into the true lumen with that technique, and we're failing. So we're getting some hematoma near the vessel. And what we've learned over time is that, okay, we're going to fail, but with STAR. I'm going to induce that in dissection. So this is a STAR technique. So you can see now the vessel is being pushed next to the lumen, and you can see the knuckle becoming bigger and then smaller. You can see that right now this wire has re-entered into the diagonal. And then with this, we came back into the LED and performed the same thing into the LED. So that part is a bit more for the doctor, but I'll explain to you afterward. So you can see now the microcatheter is being advanced. We've got a fielder XT right there. And this is a SCAD, a Stephane-induced coronary dissection, pushing really hard. This is what we don't want Mother Nature to do, but we may accept a doctor to do in some situation like this. So I've really done like what I call the Darth Vader. This is a dissection and re-entry technique with vessel integrate destruction and reconstruction. So we've really destroyed the vessel, and what we're hoping is that this will heal. So this vessel is very destroyed. The patient doesn't have any chest pain. And this is showing prior to doing anything. So surgeon will look at this and says, oh my God, I could have put a super nice lima on this, and now the vessel is destroyed. Now, but look what's going to happen 3 months later. Patient came back, and I think it's worth to put the two images next to each other. Where there was an occlusion, there's no more occlusion. There's been spontaneous healing of the vessel, and now the CTO is now in the distal LED. It's not anymore in the prox LED. So if you see right there, There's no more occlusion. So the spontaneous healing made that vessel patent. And now the only thing I had to do is reopen the distal vessel, and we finished up with putting stenting, and we had a good result. So this sort of mode of treatment that we're doing more and more, I had this in mind for a long time. And I said, like, my next SCAD case, I'm gonna do something different. So I had a 54-year-old woman without any risk factor, with non-STEMI, with ECG showing dynamic changes, ST elevation. She's still in pain. And she's transferred the echo in the other hospital showing mild hypokinesia in the inferior wall, and she's going for cath. This is the left system, and you'll see already clouds going to the PD. So I knew the right was a problem. Went to the right, and we've got this typical type 2 SCAD. Like type 2, yeah, I think it's tapering down. I'm not that good with classification, but I think it's a type 2. So, Jennifer, do you agree? Type 2? Yeah, type 2A? Okay. And then, so the RV is not flowing normally. So you see that that's the issue with the SCAD. So basically you've got a dissection or some bleeding, and then the blood fills the wall, and it's blocking the wall. So the concept of hematoma evacuation here is that you're bringing a microcatheter here, and then you're using a wire to pop boop, into the true lumen, and you empty this out. Okay? So this is, you're clearing the hematoma. That's the reason why PCI didn't work, because you're PCIing an hematoma. So you need to fenestrate it. So what we did in this case, we did an OCT, and the OCT shows a big hematoma. No surprise. And this is actually a microcatheter. I've got a wire in the true lumen, and now what I'm doing, I'm trying to get intentionally into the false lumen. So you can see now that the wire is doing some barbershop sort of wiring. So I know I'm getting into the false lumen. In the hematoma. This is a tip injection showing the wall. So this is the hematoma right there with the tip. Afterward, what I'm going to do, I'm going to use a fielder XD. I'm going to push it and watch the contrast. The contrast will just clear. So contrast was in the hematoma, and with the knuckle, popped out and flew into the distal vessel. And at the same time, STs were up. So all the content of the hematoma was released. And this is full of platelet and everything. So at this time, the patient had transient ST elevation. And afterward, I did OCT, showing that there's no more. So you can see the hematoma now is flowing, free flowing. You don't have any more staining there. It's flowing. And we got, yes, there's missing one here. This is after the start. Recuperated some flow into the vessel. Now I'm not afraid to stent because I've not got no more hematoma. And I've done an OCT. I know where to start and know where to end. So with this, we could then deliver stents, and we got a pretty good result with just a residual hematoma at the distal edge. We could size the vessel, and the patient did okay. Olga did a case in Manitoba where she had like a typical type 2B OM occlusion, as you can see right there, where she actually went with the fielder XD and popped into the true lumen. And look at now, beautiful OM reopen, typically good flow. So unresolved question obviously is like, can you do that in any anatomies? In the left main, probably, I don't know, I think I'd be thinking twice before shoving knuckles in left main in a SCAD patient, but maybe if you have to do it in a bailout situation, I would not hesitate to do it. Is there any value of deferred stenting? Do you always need to stent? Do you need to repeat the angiogram? Is there any value of DEB? We proposed this in the publication we submitted. It's a bit extending to what you presented. So basically it's like, you've got a SCAD with ongoing ischemia, and so PCI should be your first therapy. So is the wire in the true lumen? No. So therefore you have to start. You have to do something. You won't be able to get into it. So you got to start maybe going with a wire and doing cutting the lumen. Probably the start is the best way to go. If you have a wire in the true lumen, then you can fenestrate with cutting balloon, but the other option also is to go with parallel wire, access the false lumen and star it next to it. But you always leave your true lumen wire so to get back on it and then stent your vessel. The intention is just to empty the hematoma. And then, if you've emptied the hematoma by T3 flow and everything, then depending on the size of your vessel, you might be guided. If you've not emptied the hematoma, you've got an issue. You've got to consider something else to do. If you've emptied the hematoma and it looks like better, and now you've cleared with OCT, you don't see the hematoma, and you have a big vessel, probably you're okay to stent. And then you have to guide yourself what you gotta do. And if you have a small vessel, you're probably better off not doing anything and let this heal. So it obviously, so it's two cases, STAR technique showing probably some value. I think the old way of doing stenting in SCAD is probably not always ideal because you have to evacuate the hematoma before and then you're putting your stents, probably safer. But we'll have to get some more data on this. So thank you very much for your attention.